Okay, so we're going to go into some micro with the parasites here. So let's get started. This will be fun stuff. A lot of people punt this or overlook it with the USMLE, but it is asked quite often, so we need to know it. The first thing we're going to talk about is Toxoplasma gondii. Now, this is a protozoa. It has a sexual phase and an asexual phase. Now, the sexual phase is referred to as oocytes or gametophytes, and the asexual phase is referred to as tachyozoites or bradiozoites. But that's not that high yield, so don't worry about that. The transmission, you do need to know this, is ingestion of infected meat from cat feces. Cat feces. Cats are the primary reservoir and definitive host. Intermediate hosts are like birds or rodents, and incidental hosts are humans. And they have a cellular invasion by the protozoa leading to cyst formation in the muscles and the brain. Okay? In the muscles, cyst formation in the muscles and the brain, which you can see right there. So what happens is infected cells eventually rupture, releasing tachyozoites, which infect more cells and become bradiozoites again. Cats eat infected meat. That's how this gets causes. So the causes is self-limited. It's a flu-like disease in immunocompetent persons. Okay? Immunocompetent persons. In immunocompromised people, it causes toxoplasmosis, pneumonitis, myocarditis, and necrotizing encephalitis, which has multiple ring-enhancing lesions seen on the CT, which you can see right here. So if someone has ring-enhancing lesions in the brain, what could be a symptom of that? Well, you're going to get a mass effect, right? So you're going to get seizures and stuff like that. You're going to be more likely to depolarize because it's causing ischemia to this area. Now note, such ring-enhancing lesions, brain lesions, can also be seen in AIDS, lymphoma, and abscesses. In addition, metastases are usually ring-enhancing but can sometimes cause uniformly enhancing brain lesions. It's the #1 cause of encephalitis in AIDS patients. Now, this is important and it's usually tested. If a pregnant woman without previous exposure becomes infected, Toxoplasma gondii protozoa may cross the placenta, causing congenital toxoplasmosis. So this stuff can cross the placenta of affected woman. The classic triad is you get #1, chorioretinitis, #2, you get hydrocephalus, #3, you get intracranial calcifications. Alright, note that children can also can often be born asymptomatic. Now, to diagnose this, you need a biopsy showing Toxoplasma gondii or serology showing antigens. Toxoplasma gondii can also cause cysts in the brain, which calcify, which, like we said and we've talked about a couple times, cause ring-enhancing lesions seen on the CT. Okay? So, how do we treat this bad boy? You treat it with primethamine. Primethamine plus sulfadiazine. Primethamine is the most effective. To avoid bone marrow suppression, you can give something called leucovorin. That's a folinic acid rescue with primethamine, which avoids the bone marrow suppression. A lot of people overlook that. I've seen it tested on a couple of questions on USMLE World, so don't overlook that one. And that is Toxoplasma gondii in a nutshell for you. I know that's a lot of information, but the big thing to take from that is cats. It comes from cats. It can cross the placenta and cause congenital toxoplasmosis, and it can cause ring-enhancing lesions in the brain. And the most effective way to treat it is primethamine. Okay? So moving on. Babesia. What do we know about them? So Babesia is an intra-erythecoparasite protozoa. So the transmission is a bite by the Iodes tick. Iodes tick, which is the same vector for Borrelia burgdorferi, which is co-transmission is possible. It causes babesiosis, which is malaria-like. It's not malaria, but it's malaria-like. So you get fever, hemolytic anemia, and hemoglobinuria. So the diagnosis, how do you diagnose this? You diagnose it with a blood smear showing red blood cell ring formed of a tetrad form. It's called a Maltese cross. So that's a buzzword right there. If you ever see something that says Maltese cross, think Babesia. It's a good buzzword for you. And you can see that right in here. Babesia enters the red blood cells as sporocytes. They then develop into a trophocyte ring. The trophocytes become merocytes, which have a tetrad structure, aka Maltese cross. The tetrad morphology is unique to Babesia. It distinguishes it from Plasmodium falciparum infection. Babesiosis is more severe in patients who are splenectomized, or immunocompromised. Either one of those two. Splenectomized because they can no longer clear out infected RBCs, and immunocompromised, particularly patients with age. So how do you treat babesiosis? You treat it with azithromycin and, I don't even know how to pronounce this, atvaquinone. And this is for mild to moderate disease. Or you can use clindamycin plus quinone. And that's for severe disease or when patients don't respond well to the azithromycin or the adequate. Alright, and that's babesiosis for you right there. So the next thing we got to talk about is cystos. So what do we know about them? Well, you have the pork tapeworm, which is Taenia solium. You have the beef tapeworm, which is Taenia saginata. Then you got the fish tapeworm, which is, and as I was saying, Diphyllobothrium species is the fish tapeworm. And then you get the hydatiform tapeworm, which is Echinococcus granulosus. Let's write these other ones in here for you since we're having some technical difficulties. Cutaneous solium. That's the pork tapeworm. Cutaneous saginatum is the beef tapeworm. Alright, so let's talk about each one of these. What do we know about the pork tapeworm? Its definitive host is humans. Its intermediate host is pigs. It's an intestinal infection. Okay? Let's write that in there. The pork tapeworm is an intestinal infection where larvae are ingested in undercooked pork. It's an intestinal infection where larvae are ingested in undercooked pork. In the small intestine, larvae mature into adults. They can grow up to 5 meters in 3 months. Adults attach to the intestinal wall and consume food, causing malnutrition or a low energy state, as Dr. Francis would say. And gravid proglotis contains eggs and are shed in feces. You also get a tissue infection called cystericosis. Cystericosis, where eggs are ingested in food or water contaminated with human feces. In the small intestine, the eggs hatch into oncospheres, which invade and spread to other tissues. The diagnosis is an intestinal infection where the stool, you get eggs in the stool or proglotids. It's spelled like this. Eggs in the stool. So how do you treat this? You treat it with praziquantel. And the tissue infection, ceristicosis, you do an X-ray or a CT scan demonstrating calcified ceristi in the muscle and the brain. So now let's take it to the beef tapeworm. The definitive host is humans, but the intermediate host is cattle. What was the intermediate host for the pork tapeworm? Pigs. Okay? So cattle is the intermediate host here. And this is larvae are ingested in undercooked beef. So they get into the small intestine and larvae mature into adults. They can grow up to 10 meters in 3 months. Adults attach to the intestinal wall and consume food, causing malnutrition, just like Cutaneous solium. They're both tapeworms. And gravid proglotis contains eggs that are shed in the feces. So how do you diagnose this? The same way you diagnose Cutaneous solium. And how do you treat it? Praziquantel. So what about the fish tapeworm? This is Diphyllobothrium latum, the Diphyllobothrium species, the largest parasite of humans. So that is important. It can reach lengths up to 10 meters with 3,000 to 4,000 segments, each up to 2 centimeters wide. It's the largest parasite of humans. Okay. Diphrobothrium latum species are similar to Taenia solium and Taenia saginatum. Larvae are ingested in undercooked fish. The worm's uptake of vitamin B12 can result in vitamin B12 deficiency, so you can get a megaloblastic anemia. Now, the characteristic diagnosis, you get characteristic eggs in stool or occasionally evacuated segments of proglottids. How do you think you treat this? Praziquantel. It is a tapeworm. So let's talk about Echinois granulosus. The definitive host is the dog, and the incidental host is the human. Okay? The rupture of cysts that these things have, you ingest eggs and embryos spread hematogenously, so cysts form in solid organs, and usually it's the liver. Now, if you rupture these cysts, it can cause anaphylaxis. That is important to know. Cause anaphylaxis. Symptoms of a slow-growing tumor-like mass with eosinophilia is strongly suggestive of Echinois granulosus infection, especially in sheep raising areas. Its isolated hooks in the sputum suggest rupture of a lung cyst. Now this one is different in how you treat it. You treat it with a drug called benzodiazepine's, and the long course would be albendazole. So it's long. Its continued use of albendazole has been also used with varying success. It's spelled like this. So albendazole is how you treat Echinois granulosus. And those are the cystodes for you. So what about Cryptosporidium? Well, Cryptosporidium is a sporozoa. It's a protocyte with no flagella, cilia, or pseudopod motility. Its oocytes contain sporocytes, so it's use acid-fast stain to detect the oocytes. You get a fecal-oral transmission. From animals to humans. Its ingested oocytes release sporocytes in the small intestine. Now these sporocytes become trophocytes, which attach to the intestinal wall, mostly in the jejunum. So it causes self-limiting watery diarrhea. And of course, that will be in an immunocompromised patient. And also in an immunocompromised patient, it causes severe, prolonged watery diarrhea. So how do you diagnose this? Use acid-fast stain to detect acid-fast oocytes, or oocyst in the stool. Acid-fast oocyst. And that's how you detect Cryptosporidium. So how do you treat it? You treat it with nitazoxanide. And it's approved for Cryptosporidium diarrhea. Never even heard of that drug, but I guess that's how you treat it, nitazoxanide. Okay, so that's Cryptosporidium. What about Entamoeba histolytica? The key points, and this is an intestinal protozoa. causes bloody diarrhea, so dysentery. It's invasive, and it also causes liver abscesses. So the treatment, what do you think the treatment of this guy would be? Metronidazole. Metronidazole. So the protozoa with two forms, it's either a cyst or a trophocyte. The trophocyte is motile and the cyst is protective and infective. You get this from fecal-oral transmission, and ingestion of cyst from contained food and water. Cysts are passed in the stool. It's ingest 4 nuclei cyst. Cysts differentiate into motile trophocytes in the ileum. Okay? And it causes something called amoebic dysentery. Now, how do you diagnose this? Detection of trophocytes or the cyst in stool and positive serology is the best diagnosis combination. Now, the treatment, like we said, you treat invasive disease with metronidazole, then you clear the intraluminal cyst with paramycin or iodoquinol. So, to clear the intraluminal cyst, you use paramycin and iodoquinol. And that's Entamoeba histolytica for you. Giardia lamblia, a board favorite, especially in immunocompromised people. So what do we know about this guy? Well, he's a flagellate protozoa with a trophocyte and cyst forms. It's the most common intestinal parasite in the U.S. and worldwide. So remember that. Most common intestinal parasite in the U.S. and worldwide. You get it from fecal-oral transmission. You ingest ingestion of cyst in fecally contaminated water. A classic story is campers or hikers that get this. Now, cysts differentiate into trophozoites that attach to the duodenal wall via suction discs. So there's no invasion. Then you get a malabsorption with a constant fatty, foul-smelling diarrhea. That's a clue. Fatty, foul-smelling diarrhea, bloating, and flatulence. Giardia causes a foul-smelling fatty diarrhea, like we just said, and contrast this diarrhea with other protozoa diarrhea. Entamoeba histolytica causes a bloody diarrhea, whereas Cryptosporidium parvum causes a watery diarrhea. So those are all clues for the board right there. So how do you diagnose this guy? You see trophozoites and cysts in the stool, okay? And you'll see it with the antigen test. So how do you think you treat it? You treat it the same way you do a lot of other things. Metronidazole. Alright, that's Giardia lamblia. So Leishmania donovani. So Leishmania donovani is a promastigoites. Promastigotes that are infective, flagellated motile forms of protozoa. They are phagocytized by macrophages, and they mature into, this is important, amistogotes. So once the macrophage ingests the promastigotes, they they turn into amistogotes. They are non-motile, non-flagellated, and they replicate in the macrophages in the RES system, like the spleen, the liver, the bone marrow, stuff like that. So what are you going to see with that? So think about it. If it's in the bone marrow, you're going to see a pancytopenia. If it's in the liver and the spleen, you're going to see hepatosplenomegaly. So that's what happens with this guy, Leishmania donovani. Now the transmission is through blood-sucking bites of female sandfly. The female sandfly is how this happens. Blood-sucking bites through the female sandfly. Leishmania donovani causes visceral leishmanias. Leishmania tropica and Leishmania mexicana cause cutaneous leishmanias, and Leishmania brasiliensis causes mucocutaneous leishmaniasis. So how do you diagnose this? It's confirmed with a tissue biopsy demonstrating macrophages containing amistogotes, which are non-motile and non-flagellated form. That's how you diagnose it, just like we said. It's these amistogotes that how you treat this guy. Or no, not how you treat it, but how you diagnose it. So how do you treat it, speaking of that? You treat it with sodium, stibigluconate, sodium stibigluconate. It's a lysosomal amphotericin B, may also be used to treat visceral leishmanias. So that is Leishmania donovani for you. Now we're moving on to Naegleria fowleri and Acanthamoeba castellani. Now, those two are free-living amoebas. Free-living amoebas, or amoebus, that cause amoebic meningoencephalitis. Amoebic encephalitis, meningoencephalitis. That is important. That's potentially a fatal disease. Now, Naegleria fowleri has three forms. It's a cyst, a trophocyte, and a transient flagellate state. The flagellate form is motile. Now, Acanthamoeba castellani has small, thallus, or tooth-like projections that play a role in motility and probably feeding. So how do you diagnose this thing? Organisms in the CSF, specifically for Naegleria fowleri, because Acanthamoeba castellani does not always appear in the CSF. So this guy right here is going to be in the CSF, whereas this guy doesn't always appear in the CSF, but he can. And remember, these cause amoebic meningoencephalitis. That's the big take-home point there. Nematodes that are cutaneous. Strongyloides stercoralis. There are two larva forms, which is the rhabdida form or the fowleri form. Which is infective. Okay, the fowleri larvae penetrate skin. Example is on the feet. Some enter the bloodstream to the lungs, where they enter the alveoli and ascend the respiratory tract. So inflammation may cause pneumonia and are swallowed. But most larvae appear to migrate randomly throughout the body until reaching, guess where? The small intestine. Now in the small intestine, these larvae mature into adult worms that mate and lay eggs. The eggs hatch into larvae that may, number one, irritate or inflame the intestinal wall, so you're going to get a gastroenteritis or diarrhea. Number two, they may be shed in feces and possibly contaminate soil. Number three, they may repeat the infectious cycle, so it's autoinfection, especially in who? Immunocompromised patients, by invading and entering the blood. They enter the alveoli, etc., like we just talked about. So the most infections are asymptomatic, though. Signs include diarrhea and anemia. To diagnose this, you get strongyloids stool larvae. Strongyloid stool larvae. In contrast with hookworms and Acanthamoebg and Necator, in which eggs are detected in the stool. Estracolius is an invasive helminth, so look for marked what? Eosinophilia. It's a helminth, it's a worm. It's going to cause eosinophilia. So how do you think we treat this bad boy? Well, we're going to give it benzimidazoles. So thiabendazole, albendazole, or ivermectin. Thiabendazole, albendazole, or ivermectin. Alright, so let's talk about some hookworms. Hookworms, let me erase some of this so we can write this in there. So the hookworms are Acyclostoma duodenale, and Necator americanus. Now these have a filiary-form larva that penetrate unbroken skin, usually in the feet, and they enter the bloodstream. In the lungs, larvae exit the blood and enter the alveoli, so they ascend up the respiratory tract, causing inflammation and pneumonia with the eosinophilia, usually when they're swallowed. And in the small intestine, the larvae mature into adult worms which attach to the intestinal mucosa with teeth called ankylostoma or cutting plates called Necator. Adult worms may, number one, initially inflame the intestinal wall, so you're going to get a gastroenteritis and a diarrhea. Number two, they're going to mate, so shed eggs in the feces and possibly contaminate the soil. And number three, they're going to suck blood from the duodenal capillaries, which is going to cause what? Think about that. You're sucking blood, it's going to cause an anemia. So how do you diagnose this? You diagnose this with eggs in the stool. In contrast to strongyloides, which have what in the stool? We talked about this. Larvae. That's right. Hookworms are invasive helminths, so look for marked eosinophilia. Now, how do you think you treat this guy? The same way. It's a hookworm. Albendazole. Albendazole. And that is nematodes that are cutaneous. So now let's talk about nematodes that are ingested. The first one is Entamoebis formicularis, which is a pinworm. It's the most common helminth in the U.S., okay? This guy right here. The most common helminth in the United States. So you think you're going to be tested on that? You better believe it. It primarily infects children under the age of 12. Now, the giant roundworm is called Ascaris lumbricoides. And that is the giant roundworm. And that can grow up to 15 to 35 centimeters in length. Hundreds of millions are infected worldwide, mostly in where? Where do you think most people get Ascaris lumbricoides? In the tropics. Tropics. Remember that. That's a clue. In the tropics. So there's a two-host life cycle with Trichinella spiralis. In the U.S., pigs are the most important reservoir. In Alaska, what do you think fills this role? Bears. So humans are the end-stage host. Humans ingest encysted larvae in undercooked pork. In the small intestine, these larvae encysted and invade, so you get inflammation that may cause gastroenteritis. Larvae are carried by blood to, number one, skeletal muscle, where encysted larvae in muscle causes myositis, which could lead to kidney failure, releasing myoglobin into the blood. Number two, they go to the heart and the brain, so you can get a myocarditis or encephalitis. So how do you diagnose this? With a muscle biopsy demonstrating encysted larvae. Also, it's a helminth. Look for eosinophilia. So how do you treat it? Bendazole drugs, thiobendazole, albendazole, mebendazole. Okay? Let's get a new page here because we got a couple more to go. Now we got Dracula, Brachynulois medensis. Whoever named these had a sick sense of humor. Alright, this is limited to sub-Saharan Africa. So you're not really going to see this guy. You're not going to see Dracula in the U.S., okay? It's ingestion of water with larvae. It matures in the abdomen and the retroperitoneal space. 1 year later, you get worms that exit the body in the lower extremity. It causes ulceration, erythema at the exit site. So treatment is to remove the worm by wrapping it around a stick and extracting a few centimeters per day. Speed extraction with metronidazole or thiobendazole works good. The classic symbol of medicine, the rod of Asclepius, is said to come from this treatment. So that is the Draculus medensis. And then you got Toxoplasma canis. This is a canine roundworm, so humans are the incidental host. Ingestion of food contaminated by dog feces ends up with larvae that can't mature in humans, so it migrates around the body for up to 9 years. It causes blindness, if the larva reach the retina. Otherwise, it causes visceral larva migrans, which is known as VLM, visceral larva migrans. So how do you think you treat this guy? Oh, he's no different. You treat him with albendazole. See a common theme yet? So see, these ain't that bad once you get them down. Now let's talk about the nematodes, the insect vector. Alright, the first one is Acanthamoebg volvulus. Acanthamoebg volvulus. Alright, he's a fowleri nematode. The human is the only definitive host. The transmission is a female black fly that bite releases Acanthamoebg villosus larvae, which moves through subcutaneous tissue. So it's the female black fly. That releases this larva and matures into the adult form. Adults can mate and release microfilariae. Microfilariae. Fibrosis around adult form can create dermal nodules. Microfilariae cause inflammation as they move subcutaneously, leading to thick, scaly, hyperpigmented, pruritic rash known as lizard's skin. That's a clue. So if you see that, start thinking nematodes and think Acanthamoebg whatever, volvulus. So after years of infections, when this happens, you get loss of subcutaneous elastic fibers, which may cause wrinkled skin. The microfilariae may reach the eye and cause blindness, and that is known as river blindness. That's another clue, because black flies develop in where? Rivers. So Acanthamoebg is a major cause of blindness, especially in riverside villages and endemic areas. So how do you diagnose this? You do a skin biopsy that demonstrates microfilariae or the adult form with dermal nodules. And how do you treat it? You treat it with a drug called ivermectin. We've talked about that before. Ivermectin. So now, let's talk about Loa Loa. Loa Loa. This is a nematode filariae. The vectors is the horsefly, the deer fly, and the mango fly. It causes calibar swelling, so you're going to get angioedema. Of the extremities. It also migrates to the conjunctiva, so patients can sense the larva moving over their eyeball. That's what this is, the Loa Loa. So how do you diagnose it? The identification of microfilariae in blood samples allows identification of Loa Loa. Also, Warkinia bencropheti, Bergeria malariae, B. tamariae, and M. orzardi. So how do you treat this guy? This one's a little different. This one is treated with diethylcarbamazine. So the thing is, if you see angioedema, or the big clue here is it migrates to the conjunctiva, so patients can see larvae moving over their eyeball. That's Loa Loa. And we have one more. We got Wernickeia brancoffei. Graffiti. So let's get him in there. Let's get a new page here. All right. This is a fowleri nematode. Alright. Humans are the only definitive host in natural reservoir. Only definitive host in natural reservoir. So female mosquitoes deposit larvae which penetrate the skin and enter what? The lymph nodes, chiefly those of the genitals and lower extremities. After 1 year, the larvae mature into adult worms which trigger inflammation, fever, and lymphadenopathy. So over time, this leads to obstruction of the lymphatics. That is important. That's a big clue right there. Obstruction of the lymphatics over time. This causes lymphedema and elephantiasis. Wucheneriri Bancroftii causes lymphedema and elephantiasis, and like we said, lymphatic obstruction. Note, only adult worms cause elephantiasis, not the microfilariae. So you got to be an adult worm to cause elephantiasis. This is tropical pulmonary eosinophilia. Tropical pulmonary eosinophilia, where the microfilariae in the lungs cause an immediate hypersensitivity reaction with an increased IgE and eosinophilia. So what are you going to see? What's the symptom you're going to see with that? Coughing and wheezing at night. So how do you diagnose this guy? Blood with microfilariae produced by the adult worms, which circulate chiefly at nighttime. And how do we treat this? Diethylcarbamazepine or diethylcarbazine. Diethylcarbamazine. That's how you treat Rickettsia virili. And remember, your clue is that it comes out at nighttime. Alright. And it causes elephantiasis. So let's do a parasite summary. So parasites are either number 1, protozoa, which are unicellular, eukaryotes, or number 2, helminths, which are multicellular. They multitask. They're multicellular helminths. So eosinophilia typically occurs with invasive helminth infections and not with protozoa infections. This gets so confused by so many people. Protozoa does not cause invasive eosinophilia. Okay? That's only with helminths that cause eosinophilia. Okay? Now, there are 4 classes of protozoa. Number 1, you got amoebas. Now, amoebas are marked by pseudopod mobility, so examples include Entamoeba histolytica, Naegleria fowleri, and Acanthamoebg. You also have, number 2, you have sporozoa. Sporozoa are no pseudopods. They're flagellar or cilia motility. These include Cryptosporidium parvum, Toxoplasma gondii, and Plasmodium species. Number 3, you have flagellates. Flagellates. These have flagellar motility. This includes Giardia lambliat, Trichomonas vaginalis, Leishmania species, Trypanosoma cruzi, and Trypanosoma brucei. All right, and you also have Salata. Now, Salata have ciliary motility, and the one you got to remember there is Balaentidium coli is the only human pathogen in this class. So I'm going to write him down for you, because a lot of people overlook Salata, which is one of the 4 main classes of protozoa. Balaentidium coli is the only human pathogen in this class. So you think they might ask you about that? I think so. Remember, it's a protozoa. So now let's go over an overview of the protozoa diarrheas. All right, so bloody diarrhea is going to be caused by Entamoeba histolytica. Fatty, foul-smelling diarrhea is going to be caused by what? You tell me. Giardia. Good job. Now, watery diarrhea is going to be caused by Cryptosporidium. In who? Immunocompromised patients. Now, let's talk about helminths. There are 2 classes of helminths. Number 1, you got the cystodes or the tapeworms, which we talked in depth about. And the reason I'm doing an overview here is I know this is a lot of information, so that's why I want to go over this. Cystodes or tapeworms, they are adult forms that's segmented with a scolex or a rounded head and body segments, which is the proglottids. Examples of tapeworms include Cutaneous solium, which is pork associated, Cutaneous aginatum, which was the beef, Echinococcus, which was the dog, and Diphrobothrium, which was the fish. And then you have trematodes, or flukes. That's the second class. And the trematodes or the flukes are adult forms that is non-segmented with an incomplete digestive tube. So classic flukes include Schistosoma species like blood flukes, the Asian liver fluke, Colonycaris sinensis, or the lung fluke, Paragonimys westermani. Now, the nematodes are the roundworms. So the nematodes are the roundworms. They are an adult form that is non-segmented with a complete digestive tract. Or a digestive tube, I should say. Classic roundworms include Necator americanus, Trichinella spiralis, Wernickeii brancophii. So what do? We use praziquantel to treat what? Let's get a new page here so we can write this down. We use praziquantel to treat cestodes, trematodes, now the cestodes is the Cutaneous aginatum, or the beef tapeworm, or the pork tapeworm, which is Cutaneous solium. What was the fish tapeworm? Diphrobothrium latum. Yeah. Except the dog tapeworm. Now, you don't treat that with praziquantel. What you remember what you treat the dog tapeworm with? That was Echinococcus. He's treated with albendazole, the bendazoles. Okay, he's the different one, so that's the one they're going to ask you about. Echinococcus, which is the dog tapeworm. You got to treat that with albendazole. Okay? And the drug of choice for the treatment of filarius or Wucherii branchiofati, which was the worms in the eyes, is diethylcarbamazine. And that takes us to our next slide, which is Plasmodium. This will be fun. Plasmodium. So you got Plasmodium vivax, Plasmodium ovale, Plasmodium malariae, and Plasmodium falciparum. Now, Plasmodium vivax and Plasmodium ovale are relapsing malaria. So within the hepatocytes, some sporocytes form latent, dormant hypozoites, a separate form. These may activate months or years after initial infection, so periodic myrisome release, and cause symptomatic malaria in a relapsing fashion. Now, Plasmodium falciparum infections are more severe. Severe infections here. More RBCs are infected, both reticulocytes and mature RBCs, and those that are infected stick more in end organs. So you get what? Vascular occlusion, hemorrhage, necrosis, etc. It's not good. So you look for end organ damage, and that is termed cerebral malaria. That's your clue right there. So you get mental status changes. You can go into a coma. You can go into renal failure. You can get pulmonary edema, etc., etc. So how do you diagnose this? You do it with a plain blood smear or a thick and thin Gomesius stained blood smear. And the treatment for Plasmodium is chloroquinone. Or chloroquinine. It kills merozoites but not hypozoites. So high levels of resistance are developing. So you consider a combination therapy with things like adapaquan plus proguanil, or sulfadioxine plus pyrimethamine. Now I have no idea how the boards are going to go after this, but if I had to remember one, I would remember that one. Chloroquinone is how you treat Plasmodium. So that's Plasmodium for you. So now let's go on to the Nematodes. What do we know about Nematodes? This is the schistosoma. Schistosoma. So these are blood flukes. These are vertebrate-like example in humans or invertebrate snails. They have a life cycle. Now, the one that is a liver fluke is called Clonocoris sinensis. Clonocoris sinensis. And he is a liver fluke. Cerasseria escape from snail hosts and they burrow into fish muscles and become encysted metacernariae. Humans ingest undercooked fish and metaceriae migrate to where? The biliary tract. So you get biliary tract inflammation by eating undercooked fish. So I hope that sushi's worth it. Everybody likes sushi. So what are you going to get? You're going to get pigmented gallstones. Or chronic infection is cholangiocarcinoma is a risk factor. So how do you treat this guy, Nematodes? Well, we use praziquantel again. So you're starting to see a theme now. We use certain drugs a lot. So there's one more thing here with the Nematodes that I want you to be aware of, and that is Paragomys westermanae. Paragomys westermanae. He is a oriental lung fluke. So ingestion of raw infected crustaceans cause larvae to migrate to the abdominal wall and liver, and adult flukes migrate to the lungs. So you're going to see hemoptysis and cough. You treat that also with praziquantel because he is a trematode. All right, let's talk about Trichomonas vaginalis. So this is a protozoa with one nucleus and 5 flagella, so it's motile. It's the size of a white blood cell. It exists only as a trophocyte. An example is Giardia, Entamoeba, etc., which exist in both cyst and trophocyte forms. It's usually asymptomatic, but when it's symptomatic, it's in women. It causes a vaginitis. Causes vaginitis with an intense vaginal itching or burning, foul-smelling, yellow-green, frothy vaginal discharge, and that's known as a strawberry cervix. So the strawberry cervix is a bright red, and it's due to vigorous inflammation, which is a response. So it's a classic finding on the speculum exam. So in men, you see urethritis. But in women, you see this vaginal discharge. So how do you diagnose this? You do a vaginal swab, and you put it on a wet mount, and you visualize a teardrop. A teardrop, which is a pear-shaped, ovoid-shaped trophozoite with tumbling corkscrew motility. So how do you treat this guy? Well, you treat it with metronidazole. You treat both the patient and their sexual partners. Metronidazole. So the last thing we are going to talk about is trypanosoma. So trypanosoma has Trypanosoma cruzi. Trypanosoma cruzi is a flagellated protozoa. It's the kissing bug or the red duluva bug. It's the kissing bug. So it bites patients and defecates nearby. So the patient scratches the feces containing tropomastigotes directly into the bug bite. So flagellated tropomastigotes get into the blood and become non-flagellated mastigotes within cells. So you get cardiac and neuronal damage. And this causes something called Chagas disease. That is very important. You will be tested on this. Chagas disease, Trypanosoma cruzi. This is American trypanosomiasis. It's acute and chronic forms. Its acute form is flagellated tropomastigotes on blood smear with inflammation at a bite site. They call that a chagoma with congestive heart failure. The acute form usually resolves within 2 months and may progress to a chronic form. Now, the chronic form shows biopsies shown with non-flagellated mastigotes within cells, especially where cardiac muscle. So patients start to develop with the chronic form cardiac arrhythmias, dilated cardiomyopathy, megacolon, and megaesophagus. The reservoir host for Trypanosoma cruzi is humans and animals, domestic and wild, especially in rural South and Central America. Now, how do you treat this guy? You treat him with albendazole and nitrofuramox, only for the acute form though. Spelled that wrong. Nifurtimox. Acute form only, and you can treat it with bendazoles. Now, to treat the chronic form is supportive care alone. Then you have something called Trypanosoma brucei. We'll get a new page for him. So Trypanosoma brucei he has a subspecies of Gamebus and Rodentius. Both are flagellated protozoa. Now, T. gamensis is found in West and Central Africa and causes a chronic form of the disease, while Trypanosoma rodentius is found in South and East Africa and causes a more acute form. So let's write that down. Both are fatal if untreated. Now, the transmission, you get bites of infected tsetse flies, only in Africa. And that is spelled T-S-E-T-S-E, tsetse flies, only in Africa. So when you want to go to Africa, think twice about that. It causes African sleeping sicknesses, okay, or African sleeping sickness. It's a two-stage disease. The early stage, you get intermittent fever, malaise, headache, the boo-boos, you know. The late stage is in the CNS, so you get daytime somnolence and nighttime insomnia and persistent headaches. To diagnose this, you have to have an identification of mobile trypanosomes on a blood smear. Trypanosoma brucei is rarely found as a mastigotes, okay, which are non-flagellated protozoa within cells and tissue. Now, in contrast to Trypanosoma cruzi and Leishmania species, in which mastigotes are commonly found, okay. So the early stage before CNS infection, you treat that with something called Samarin. Or Sumarin. Sumarin is in early stage. In the late stage, you treat it with Melarsoprol. In the late stages where CNS infection is the underway. Alright, and that is your parasites for you for what you need to know for the USMLE. It's not crazy high yield, but I would definitely know the high yield stuff about the parasites, because you never know, they could throw all kinds of them at you, and there's tons of information in it. It's boring, but go over it and make sure you know most of it. Alright. Diphyllobothrium species.